This is the presentation on vascular surgery. A few objectives for the presentation today would be to be able to identify common arteries in the abdomen and lower extremities, discuss the most common equipment utilized in vascular surgery, differentiate between common vascular procedures, and integrate that new knowledge into your practice. First, what is vascular surgery? Vascular surgery is simply defined as procedures that treat injuries and disorders of the arteries, veins, and lymph vessels in the body. This can be done through an open approach, where they would make a large incision in your abdomen, over your leg, your arm, or we can do it endovascularly, where they make a small incision directly into an artery. Indications for vascular surgery can include aneurysms, like aortic aneurysms, any blockages of vessels, any venous disease, like peripheral vascular disease, a vascular trauma, or need for dialysis access. So there's no quiz over all of these arteries of the abdomen, but I just thought that this picture was cool and kind of illustrated just how complex the vascular system is in the abdomen. This picture as well kind of shows arteries and the veins on the left, and then all the arteries are labeled here on the right. And then just kind of a closer look at all of these smaller arteries branching off the aorta. The iliac artery is very common for us to do a lot of work in, as well as the renal arteries you can see up there kind of in the middle to top. Occasionally like the mesenteric right there in the middle, but those we work in a lot. And then here's some arteries of the lower leg. So you can see the femoral artery, femoral vein. We do access the femoral artery for a lot of endovascular procedures, so that's an important artery to know where it is. And that saphenous vein is important because they will take grafts of the saphenous vein in certain procedures. And then lower, kind of just knowing where those arteries are. The popliteal is important. Tibial arteries are important. I don't know if you've ever heard somebody say, oh, they had a fem pop or a fem tib, and that's when they're doing bypasses in the lower legs, and we'll talk about that later, but those are the arteries that they're accessing. So some common vascular procedures are an angioplasty, AV fistula creation, that would be for dialysis access, carotid endarterectomy, abdominal aortic aneurysm repairs, peripheral artery bypass, and that's what I was talking about, the fem pop or fem tib bypasses, or an IVC filter placement, so that's that inferior vena cava filter. We're just going to talk a little bit about each one. So first, angioplasty. Angioplasty is used to block open arteries. Another name that you might see is an angiogram or an arteriogram, and that's basically just the radiologic imaging of the arteries. The angioplasty is where they're going in and actually having an intervention. So procedure is pretty simple. They usually make access, femoral artery. They put up a guide wire. They will find the area that is blocked that they need to open up. They will put a balloon to kind of dilate that area, put a stent in to keep that area open, and then close the wound. Because they have access to your femoral artery, you obviously want to make sure that there's no excessive bleeding. So they either have special devices that they can close up the femoral artery with, or they can hold pressure for an extended amount of time, usually 3 to 5 minutes, sometimes up to 10, kind of depends on what the procedure. There is a link to a video on angioplasty, which I will post. I think it does a really good job of explaining exactly what they're doing if you just want to kind of see it or you want a little more clarification. This is kind of what you would see if you were in the endovascular room. So this left set of pictures, picture A, you can see that that artery is not open. There is a lot of stenosis there, maybe a blockage. And then in B, they have went in, ballooned it, opened it up, maybe put a stent in. and that blood flow is very dark, very straight now. On the right side of the picture, kind of the same thing. They have that narrowing before the angioplasty, and then after the angioplasty, it is wide open. So that is the goal for every procedure. Complications from this procedure can include bleeding, can include infection. Usually the patient has a very low risk for any complications from this, depending on if they have pressure or the special device placed to close their artery. They might need to lay flat for a certain amount of time. But generally these patients do well and can get up and potentially go home the next day, kind of depending on what their other diagnoses are. The next procedure I want to talk a little bit about are AV fistula creations, or arteriovenous fistulas. You might have worked with a patient through your nursing school that has been on hemodialysis that has had an AV fistula. And this is simply just a surgical connection between an artery and a vein, and it is used to give the patient dialysis. So these patients are often in end-stage renal disease and their kidneys are not functioning well, or maybe at all. They might be on a transplant list. So they need to have their blood filtered because their kidneys aren't doing it for them. So these patients will come into surgery. The surgeon will make an incision in their lower arm. Usually the AV fistula can be in a variety of different places, but typically it's here, as shown in this picture. After the surgeon makes incision, he will dissect down and mobilize the vessel and the artery that he wants to utilize. He will perform an anastomosis and connect that vein and artery together. Check pulses to make sure the blood flow is working well, and then they will close up. I do have a link to an AV fistula procedure that I think explains it a little better, but it's very basic, very easy to understand. AV fistula creations do take time to mature, so the patient cannot use this right away. They have to wait usually a week or to 2 weeks before they can use this. Complications from this can include bleeding. There could be a leak between the artery and the vein. Patient could lose blood flow to any areas that are below the AV fistula, so the fingers or the hand in this example. There could also be an infection. The patient could suffer other complications due to their disease process. Post-op care for this patient would just be to make sure that you are providing good vascular, neurovascular checks. You're making sure that they have good pulses in their hands, making sure that we don't do any blood pressures on that side, don't do any blood draws down by the fistula, just making sure we're really taking good care of that fistula and that there's no signs or symptoms of infection. Next procedure I want to chat a little bit about is a carotid endarterectomy. This procedure is when we are removing plaque from the carotid artery. So the carotid artery is in your neck. You have a right and a left carotid artery. It supplies blood to your brain. So when it is full of plaque, you have a high risk for stroke. Additionally, you have reduced blood flow to your brain, so your risk for stroke is higher. In this procedure, it can actually be done a couple different ways. We can do an open approach or kind of like an endovascular approach. And in this open approach, the surgeon will make an incision on the side of your neck, dissect down until they find the carotid artery, remove the plaque, place a patch, and close up the wound. Complications from this surgery can include having a stroke because pieces of that plaque can break off and travel to your brain. Additionally, patients who have carotid endarterectomies might potentially need a surgery on the other side. They will also have to have, diet, exercise modification after the procedure and follow a heart-healthy diet. Another way that we can do a very similar procedure is this TCAR, is what we call it, or a transcarotid artery revascularization. And what they do for this procedure is they actually go in, make a percutaneous approach to the carotid artery, After they've have access to the carotid, they place this device which reverses the blood flow. So instead of the blood flowing towards your brain through your carotid, it's actually pulling the blood away. Because of gravity, they hook it to your femoral artery, so it will flow into your femoral, get recirculated. This is really good for the patients because it's a little more minimally invasive. As well, it has a decreased risk of stroke because the blood and any clots that are breaking off from that plaque are flowing away from the brain and they're getting trapped in this little device. It's kind of a cool procedure. We do this in our endovascular room, and I will post this link to the procedure if you want to just give it a quick watch. Complications from this procedure would include bleeding, pain at the site. Usually these patients do really well. They can go home after a couple days. They actually do really well. Next thing I want to talk about is an abdominal aortic aneurysm. You may have talked about this before, and it always sounds very scary. Sometimes it is. This can be an emergent procedure if the patient comes in with a rupture or a dissection. But an abdominal aortic aneurysm in and of itself is simply just an enlarged area of your aorta. It is actually not recommended to undergo surgery until your aneurysm is greater than 5.5 centimeters. And that's a recommendation by the American Heart Association. If your aneurysm is larger or it does rupture or dissect, you would come in for an abdominal aortic aneurysm repair. We can do this open or with an endovascular approach. If we are doing it open, it's very, very simple. You make a midline incision in the patient's abdomen. They clamp the aorta to stop blood flow to the area. They will repair the aorta with a graft, and they will close up. They make sure blood flow is working and that their graft doesn't have any leaks, obviously. But it does take about 2 to 3 hours. I know I've made it sound super simple. We can also repair this via an endovascular approach. So if we are repairing this aneurysm endovascularly, as you can see in this picture, they will make access through one or both of your femoral arteries, occasionally, usually both. They will run a guide wire up and then place a stent up, as you can see in that right-sided picture. So access, guide wire, they place the graft, and then they will close. This is a good example comparison side by side of a patient who's had an open repair versus a patient who's had the stent grafts and an endovascular repair. Reasons for different types of repair could include patient's anatomy, the seriousness of the case. If the aorta has already ruptured and there's no way that the surgeon thinks that it could be repaired with an endovascular approach, they might elect for an open procedure. It kind of depends on patient condition. Complications for this can include a wide variety of things. Often these patients who have aortic ruptures sometimes don't even make it to surgery. And actually the statistics for aortic dissections, once the aorta ruptures or dissects, the statistics for survival are actually very low. It's about 30%. But if you just have an abdominal aortic aneurysm and it's caught before it ruptures, there's a like 90% chance of you surviving and going on to live a full life with the stent graft. So, and that is simply because once it ruptures, you lose blood so fast that it's very, very hard to get in there quick enough to make the repairs. After this surgery, if it's an open approach, the patient will stay for a little bit longer. An endovascular repair, they might stay in the hospital for 3 to 4 days, just kind of make sure they're recovering well, and then they can go home. They'll be on, normal lifting precautions, following a heart-healthy diet, and monitoring their vascular hemodynamics. Next surgery I want to chat a little bit about is a peripheral artery bypass. So this is when a blocked artery is bypassed with a graft to restore blood flow. In a lot of these procedures, the saphenous vein is harvested to perform this bypass. This is, as I mentioned earlier, where you might hear they had a fem pop, a fem tib, a fem, and what they're doing is bypassing that area. So the procedure is you make the incision, they expose the artery that they want to bypass. In this procedure, they want to bypass from the femoral to the popliteal. So this would be an example of a fem pop bypass. They harvest the vein. They can also use an artificial graft. They will place the graft and perform the anastomosis, sewing the graft in to both arteries. They will use a little Doppler to ensure that they have good blood flow and they can hear pulses, and then they will close up. Complications for this surgery can include neurovascular damage, bleeding. The anastomosis sometimes can leak, so bleeding can occur. But these patients generally do pretty well. They often will go to the ICU just to ensure that everything's okay for closer monitoring overnight, and then they'll generally go to the floor. IVC filter placement. It's an inferior vena cava filter placement. This is done to prevent blood clots from going to the lungs. So this can be done in patients that have a blood clot in their lower extremities, in their arms, somewhere in their body, and we want to prevent that from going into their lung. It can also be done prophylactically to prevent blood clots that may form from going to the lungs. They make an incision, usually in the femoral artery. They will place the filter, or they'll run a guide wire up, run the filter up, open this little umbrella filter up, as you can see, and then they will close. They'll put pressure on the patient's femoral artery until the bleeding stops. Complications for this procedure: sometimes the IVC filter can become dislodged or not be in the correct place. That's very rare, but it could happen. The patient could get a blood clot anyway, but generally this is a low-risk procedure. So we do have an endovascular suite. I know that we kind of briefly saw it on the tour. Everybody freaks out, but I promise, stay calm. The endovascular suite has a lot of equipment in it, but it's not so scary once you are comfortable with it. So some equipment that we have in here that's kind of important: we have a power injector, crosser, angiojet, Rotarex, and ultrasound. These are the 5 main things that kind of are specific to the vascular room. So first we have this piece of equipment. It's called the power injector, and it just basically injects high pressure contrast for visualization. So if you're working in a little tiny artery, it's very easy to inject a little bit of contrast and you can see what you're doing. If you're working in the aorta or a really large artery and you need to inject a high volume of contrast, it's very hard to do that manually by hand. So this machine does all the hard work for you. This machine is called a crosser. It utilizes high-frequency mechanical vibrations to break up clots. It is used when a patient has a total occlusion, so when their artery or vessel is blocked off completely. It utilizes cold normal saline and just sends these mechanical vibrations and breaks up the clots. This machine is called an angiojet, and it will break apart and remove fresh thrombus. So if a patient has a blood clot that has just formed recently, still kind of soft, they can use this angiojet to break it up. Additionally, this angiojet can inject TPA into the patient's artery, and it can break up the clot directly at the source. So anytime they're doing a procedure called a thrombectomy, that might indicate that they might utilize this machine. The Rotarex is another cool piece of equipment. They can do this for arthrectomy or thrombectomy. So this means if they have a hard total occlusion clot or a fresh thrombus, they can use the Rotarex for both. We also have an ultrasound that we use for a lot of the procedures at the beginning. We want to get good access. We want to make sure that we're in the right artery. So they often use this GE ultrasound just to visualize the arteries and the veins to make sure they're making access at the correct spot. Okay, well, I know that was a super brief overview of vascular surgery. That one was a little quicker than the other presentations. I just wanted to give you a little bit more information. I didn't want to get too detailed into vascular surgery because I know you all will be spending time in the CVOR this week. But I just wanted to brief information. Here are some references if you do want a little bit more information on vascular surgery. But yeah, I hope you have a great week.